Good morning, everybody. And thank you for the organizers for giving me the opportunity to talk about it. Actually, it's a very short topic which I wanted to stress upon. What is in limited stage SCLC? What do we talk about concurrent chemotherapy? I'll just skip the part. But about the diagnosis and staging, so we generally see that T1, T2, N0, M0, that is the stage 1, limited stage as per VA staging, has an incidence of somewhere around 5%. And the limited stage as per the VA staging otherwise, other than stage 1, that is stage 2 and 3, includes somewhere around 30%. So in general, we are looking at 35% of the patients and how do we change the management. So this is sort of an NCCN adaptation only. In clinical stage T1, T2, N0, if you have got pathological mediastinal staging negative, these are the only very few select patients who can consider lobectomy and mediastinal lymph node dissection. Adjuvant-wise, N0, systemic therapy, N1, systemic therapy with or without mediastinal RT, sequential or concurrent, and N2, systemic plus mediastinal RT. But the other ones, this is the pathological mediastinal staging positive or medically inoperable or decision made not to pursue surgical resection. These are the ones which we divide into good PS, poor PS, and poor PS not due to SCLC. So in the good PS, it is no-brainer that systemic therapy with concurrent RT. In the poor PS, you might consider systemic therapy with or without RT as in concurrent or sequential. In the poor PS 3 to 4, not due to SCLC, you would consider individualized treatment, including supportive care. So standard of choice is concurrent chemotherapy with RT. Standard chemotherapy is combination etoposide and cisplatin 4 cycles. RT timing and dosing, 1 dose, ma'am has already talked about. So there was, this is the trial by Sanders et al. Published in 2002 in a JCO paper, where they combined, where they compared in EP versus CEV, that is cyclophosphamide, etoposide, and vincristine for 5 cycles in SCLC. There were 214 patients, RT for 3 weeks after CT cycle 3. So it was not an idealized trial, but PCI for patients with CR, this was what was standard anyways used. OS favored EP over CEV by a big margin. That is, the median OS was 14.5 versus 9.7 months. 2-year OS of 25% versus 8%, and a 5-year OS of 10% versus 3%. So this made EP as a standard regimen for concurrent CTRT. So there is always a question whether carboplatin versus cisplatin, which one of them is the better one. But nothing has been done for limited stage, but in extensive stage, there are multiple meta-analyses which have told that carboplatin has more hematological toxicity and cisplatin has non-hematological toxicity more. So it is individualized decision which one to use. Any other regimens, any other drugs to be added, nothing has really worked over this. Ma'am has already talked about radiation, so I'll just skip part whether this was a Convert trial which talked about BD versus OD concurrent CTRT in limited stage SCLC. What it did show is twice daily RT had a median OS of 30 months versus once daily RT had a median OS of 25 months. 1 year 83% versus 76%, 2 year of 56 versus 51, and 3 year of 43 versus 49. But then again, this did not added to statistical significance. Toxicity wise and in general toxicity wise, it is a treatment related neutropenia grade 1 to 2 twice daily had 13.7 versus once daily had 18.7%. But the grade 3 to 5 twice daily was slightly more toxic as compared to the once daily regimen. Grade 3 to 5 esophagitis, which is again a major problem, almost equal between the two arms at around 20%. Grade 3 to 5 pneumonitis, which is sort of a late sequelae, and that's from radiation pneumonitis, was more in the once daily arm as compared to the twice daily arm. So with aggressive concurrent chemoradiation, there's a high likelihood of response, even CR. Problem is possibility of long-term disease for survival still is dismal, and most patients will almost certainly relapse. So why do we need effective therapies? Very little progress has been made in the past 30 years. Poor outcomes dependent on disease extent, limited stage median OS is around 15 to 20 months with the best of things that we have, and 6 months increase in survival versus the control arm. This is what we have achieved till now. So is there no hope in sight? There is, probably, with ongoing trials of immunotherapy in SCLC in limited stage. So post CTRT durvalumab, this is the Adriatic first line consolidation in limited stage, plus CRT with nivolumab and ipilimumab stimuli trial. This is also ongoing. IO plus IO combinations are in the picture. IO plus chemotherapy, this is something which needs to be considered if we have to move forward and if we have to move forward fast. IO and targeted therapy with durva and olaparib. Obviously, this is in the extensive stage, but probably over a period of time, this might come back in the limited stage as well. So this is the Adriatic consolidation durvalumab versus durvalumab, tremelimab versus placebo in limited stage SCLC, the schema. So there are 3 arms: durvalumab plus placebo, durvalumab plus tremelimab plus durvalumab plus tremelimab, and placebo only. This is given post 4 cycles of this one with or without PCI. This is the NRG LU005 studies where concurrent CTRT versus CTRT plus atezolizumab. This is again something which needs to be watched out for as whether this improves survival. Then there's a stimuli trial, which is a phase 2 trial of consolidation nivo and ipi in limited stage SCLC after chemoradiation. Again, there will be many talks on this, but this is something which might change the picture in the coming months. So to summarize, with aggressive concurrent chemoradiation, high likelihood of response, even CR, but possibility of long-term disease survival is poor. Most patients will relapse. Stimuli trial did not mean its primary endpoint of improving PFS with nivo-ipi consolidation after chemoradiation in low-dose SCLC, but there were many negative points about it. And treatment for advanced SCLC are an unmet need with standard of choice remaining unchanged for decades. And LS SCLC standard of care is concurrent CTRT. Checkmate 32 with nivo plus or ipilimumab is now guideline recommended second or third line option for advanced SCLC, but we'll talk about it later. But questions still remain. Choice of nivo monotherapy versus combination is personalized. PD-L1 expression testing did not appear to identify a benefit in SCLC. Thank you.